Welcome to the InnoGuide Podcast, where we share the works of authors and mentors to guide innovation. In this episode, number 53, we'll be sharing part one of The Great Healthcare Disruption by Marshall Runge, MD. Welcome to the introduction of this book, a front row seat to the most dramatic transformation medicine has ever seen. We're living through a revolution in healthcare, a time when the pace of change is so rapid and so profound that it's hard to keep up. Imagine a world where diseases that have haunted humanity for centuries are wiped out in mere months, where therapies not only extend our lives but also vastly improve their quality. This isn't a distant dream. It's happening right now thanks to breakthroughs like mRNA vaccines, gene therapies, and new obesity drugs. The engine behind this acceleration? Artificial intelligence and technologies that once seemed like science fiction. But with all this promise comes a set of daunting challenges. The cost of innovation is threatening to widen the gap between those who can afford care and those who cannot. Traditional institutions, hospitals, and academic medical centers are being challenged by new, well-funded players with bold ideas. As someone who has spent 4 decades in medicine, I've seen incredible progress. When I started as a cardiologist, treating a heart attack was mostly a matter of waiting and hoping. Then, in the 80s, everything changed. New drugs could dissolve clots, stents could restore blood flow, and devices like defibrillators saved countless lives. Yet, even with all that progress, the current wave of change, especially in cardiometabolic diseases, makes me believe that we ain't seen nothing yet. This new era is both exhilarating and challenging. It raises tough questions. Who will benefit from these advances? Who will be left behind? How do we ensure that everyone gets the care they need as the system is disrupted? Medicine is not just a science or an art. It's also a business. And it's about adapting quickly. Those who don't keep up will be left behind. This is especially true for academic medical centers like Michigan Medicine, where I serve as Executive Vice President, Dean, and CEO. Academic medical centers, AMCs, have a unique mission, training future caregivers, conducting cutting-edge research, and translating discoveries into treatments for the toughest cases. To stay relevant, AMCs must remain vibrant hubs of innovation, form new partnerships, and find ways to improve access to care. This book is my attempt to map out the forces reshaping medicine. Healthcare is a massive industry, but it's also deeply personal to me. My family's roots in medicine run deep. My grandfather delivered my mother at home during a snowstorm, and my parents both became doctors. My mother was a pediatrician helping children with learning disorders, and my father was an internist and cardiologist who made house calls in the late 1970s. I see healthcare as a patient I care deeply about, and I want to see it thrive. Our challenge is to preserve the best of medicine, especially the human connection between doctor and patient, while harnessing the power of technology and new approaches to care. Let me give you a personal example. Last year, after my own hip replacement surgery, I faced a rare complication that nearly became life-threatening. What saved me wasn't just advanced medical care, it was the ability to recover at home, thanks to Michigan Medicine's Hospital Care at Home program. I received medications, supplies, and diagnostic testing at home with in-person and remote visits from doctors and nurses. This patient-centered approach accelerated my recovery and showed me that hospitals aren't always the best place, even for the sickest patients. It's a powerful reminder that we need new forms of collaboration and care delivery. With this book, I want to spark conversations about the future of medicine. I want you to think critically about the impact and quality of care that can result from these disruptive changes. We'll look at innovative programs from around the world. We'll examine how companies like Amazon and Google are creating new markets for 24/7 retail medicine, and explore how disruptors are reshaping pharmacies and making drugs more affordable. We'll also dive into the transformation of behavioral health, in-hospital care, and at-home care. A central theme is the transformation of medicine by AI. We'll analyze how AI can expand the types of care specialists can offer, support better diagnostics and drug development, and create personalized treatment plans. AI is already being used to manage chronic diseases and improve access to mental health care. But we must also consider the complications. Will AI replace most care providers? What about the privacy risks and cybersecurity threats that come with massive data collection? We'll also tackle tough questions about health equity. How do we handle the high cost of new treatments? Who should have access to expensive drugs and gene therapies, and who should pay for them? Throughout this book, I'll bring in other experts and share stories from patients and providers to make sure we understand the real-world impact of these changes. It's not just healthcare that's being transformed. It's how, when, where, and by whom care is delivered. My goal is to inspire you with a vision of what's ahead, to share my excitement, and to encourage creative thinking as we enter this new era. Change isn't just coming, it's already here. Fixing American healthcare means challenging old assumptions and leading real change. Criticism alone won't fix the system. We need solutions. Despite our victories against major diseases, we still lag in preventive care. Costs are out of control, and our life expectancy trails other developed nations. This may seem overwhelming, but as Churchill said, those who never change their mind never change anything. Change is not just necessary, it's the only way forward. My own views have evolved dramatically. I never imagined I'd advocate for the federal government to take responsibility for basic health care, but now I believe it's essential, balanced with the transformative power of technology and entrepreneurship. Advances in AI, data analytics, and biotech offer unprecedented opportunities, and entrepreneurs will be the key to driving progress where traditional systems have failed. In this book, I'll lay out where our system is failing and, more importantly, how we can chart a new course, one that combines bold policy changes with innovation and entrepreneurial spirit. Together, we can make a difference. Let's get started. Chapter 1. Reimagining Healthcare. Let's dive into the heart of the matter. The U.S. healthcare system is quite frankly the most expensive in the world, and yet it's not delivering the health outcomes we should expect for that investment. That's the paradox at the center of this chapter. We have dazzling technology, world-class emergency care, and highly specialized treatments, but the system is fragmented, inefficient, and often inequitable. If we want to become a healthier society in the next decade, we need to face these realities head-on and ask, how do we lead the way, both as individuals and as a system? The state of American healthcare. Let's be honest, the data is sobering. Life expectancy in the U.S. has stagnated. Obesity rates have tripled since the 90s. Type 2 diabetes and heart disease are on the rise. Mental issues, depression, anxiety, suicide are surging, often alongside substance abuse. Maternal mortality rates are climbing, especially for Black and Native American women. Despite our medical advances, these problems persist and are incredibly costly. That's why so many disruptors, tech companies, entrepreneurs, and innovators see opportunity in healthcare. They're not just bringing new gadgets and drugs, they're challenging the very structure of how care is delivered. But let's be clear, not every part of the system is ready to adapt. Some will thrive, others will struggle, and the pace of change is unlike anything we've seen before. Our system is a patchwork of independent parts, not a single unified whole. The disruption we're experiencing is touching every aspect of healthcare at once. To manage this, we need to think holistically, see the forest and the trees. That means questioning our assumptions and being willing to reconfigure the system from top to bottom. Some changes are big and flashy, like revolutionary new therapies or data-driven procedures. Others are surprisingly small, but no less impactful. Take Irwin, a 66-year-old swimmer who came to Michigan Medicine. After years of heart trouble and a failed ablation, he was facing the prospect of a traditional pacemaker, bulky with wires that can break. Determined to avoid surgery, Irwin improved his health through diet and exercise, but his heart rate kept dropping. Enter the Micra AV, the world's tiniest pacemaker, so small it can rest on a nickel. Implanted via catheter, it has no wires, reducing infection risk and speeding recovery. Just a week after his procedure, Irwin was back in the pool. His story is a perfect example of what happens when we reimagine what's possible and challenge our assumptions. The mythology of medicine. Let's talk about this mythology that shapes American healthcare. We have a set of core expectations, some philosophical, some practical, some economic. Here they are. There are 6 of them. Healthcare is a fundamental right, number 1. 2. Patients should get the right care at the right time in the right place. 3. We can't ration care or have a 2-tiered system. 4. Insurance should pay for whatever treatments are needed. 5. Companies have the right to grow and profit. And 6. We must reduce healthcare's share of GDP. The problem? These expectations aren't all compatible. Limitless care isn't possible in a world with limits. Many new treatments like Ozempic, Wegovy, Mavenclad, Adulam are extraordinarily expensive, sometimes costing tens or hundreds of thousands of dollars a year. Who pays for these breakthroughs? Big pharma, insurers, health systems, the government, or patients themselves? Every solution has trade-offs, and every action has consequences. Americans pay more for drugs than anyone else, fueling frustration but also funding global innovation. Insurers are often vilified, but they employ millions. A government-run alternative could mean massive job losses. Health systems face the dilemma of prioritizing growth and innovation versus serving the underserved. No single sector can absorb the full cost of change. Real progress requires a balanced collaborative approach that sustains innovation, economic stability, and equitable access. What about personal responsibility? Should we as patients do more to prevent illness, like Irwin did by exercising, eating better, and improving our sleep? Prevention is the obvious answer, but it's notoriously hard to implement at scale. We haven't yet figured out how to incentivize healthy behaviors across large populations. Per capita spending in the U.S. has skyrocketed from $353 in 1970 to $13,493 in 2022. Total spending has ballooned from $74 billion to $4.5 trillion. Are we getting a good return? Some say yes. Others point to better outcomes in other countries and say no. Global lessons. Let's look beyond our borders for perspective. The U.S. spends more per person and as a share of gross domestic product, GDP, than any other high-income country. Yet we have the lowest life expectancy, highest rates of avoidable deaths, and the highest maternal and infant mortality. Obesity rates are soaring, and we see doctors less often than our peers abroad. For example, in Denmark, they have universal health insurance funded by taxes, with primary care physicians acting as gatekeepers. Wait times can be long, but life expectancy is higher than in the U.S. Singapore uses a 3Ms system: MediShield Life, catastrophic insurance, MediSave, mandatory savings, and MediFund, a safety net. But patients pay a lot out of pocket, creating a two-tiered system. Singapore's life expectancy is even higher, but access to expensive care can be limited. Cuba, often cited for its high vaccination rates and low infant mortality, achieves these with a focus on prevention and primary care, but specialty care is scarce and basic care can be unreliable due to economic hardship. Dialysis, for example, is available to far fewer people than in the U.S. or Europe. The lesson? Every system has strengths and weaknesses, and the metrics you use matter. No country satisfies all our expectations. As the Rolling Stones put it, you can't always get what you want, but if you try, sometimes you might find you get what you need. The metrics. Here's a quick snapshot. Life expectancy. Singapore, 84. Denmark, 81. U.S., 76. Cuba, 74. Obesity. Singapore, 12%. Denmark, 18%. Cuba, 43%. U.S., 43%. COVID-19 vaccination rate. Singapore, 90%. Cuba, 88%. Denmark, 82%. U.S., 68%. Infant mortality per 1,000. Singapore, 2. Denmark, 3. Cuba, 4. U.S., 5. Health spending as a percentage of GDP. Singapore, 4%. Denmark, 10%. Cuba, 14%. U.S., 17%. I'm not suggesting we copy Denmark, Singapore, or Cuba, but we can learn from their focus on population health and regular evaluation of outcomes. We need to track progress, integrate clinical medicine with wellness, and distribute resources more equitably. Here's what Thomas Friedman calls a Promethean moment, a time when new tools and ways of thinking force us to change everything, not just tweak around the edges. The challenge is to manage these changes so that more people benefit from breakthroughs and to shift our mission from sick care to true health care. Consumers are driving this transformation. They want affordable, accessible care and doctors who see them as individuals. Much of healthcare innovation has been about making money, but can we also direct our entrepreneurial energy toward improving health itself? Programs like the NIH's Clinical and Translational Science Awards, CTSA, show what's possible when we build collaborative networks to address health disparities and respond quickly to public health needs. These partnerships go beyond hospitals to engage communities where people live, work, and gather. We've seen plenty of the flashes in the pan in healthcare, leading to skepticism, but this time feels different. We can't ignore transformative innovations or wait for a few pioneers to test every disruptor. Our mission must remain clear: improve health before, during, and after treatment. Disruptors, especially those backed by investment groups, may be motivated by profit, but if they deliver better service, more customized care, or 24/7 access, that's an opportunity, not a threat. Given the long-standing problems in our system, we should welcome disruptors as potential partners in reconciling out universality, profitability, and cost containment. Let's own our future. Let's reimagine healthcare together. Chapter 2, Retail Medicine. Let's talk about the new face of healthcare, one that's looking more and more like your favorite retail experience. The principle at the heart of this chapter is simple but profound. As our population ages and we face a growing shortage of doctors, nurses, and other healthcare workers, we're forced to rethink how care is delivered. Disruptors, companies, and technologies that shake up the status quo are opening up new channels to reach more people, but they're also fragmenting care in ways we need to manage thoughtfully. Learning from Nike, the customer experience revolution. To set the stage, I want you to think about Nike, yes, the shoe company. Nike has mastered the art of a seamless, personalized customer experience, whether you're in a store, online, or using their app. The Nike Fit app, for example, uses augmented reality to measure your foot with your phone's camera, ensuring you see shoes that fit you perfectly. Imagine if healthcare worked like that. Your health data would follow you wherever you go, and you'd have 24/7 access to a provider who knows your history and can prescribe the medication delivered to your door within hours. Amazon's bold entry. Enter Amazon with its 2022 acquisition of One Medical and earlier purchase of PillPack. Amazon is building a healthcare ecosystem that's all about convenience, affordability, and personalization. For about $49 per telehealth visit or an annual membership fee discounted for Prime members, patients can access primary care, manage chronic conditions, and get preventive screenings, all virtually or in person. Amazon's approach is to use its data and logistics prowess to make healthcare as easy as ordering a package. But this business-oriented approach isn't for everyone. Some find it off-putting, but it's a recognition that healthcare is, in many ways, a business, one with a noble mission, yes, but a business nonetheless. Scott Powder, a strategy leader at Advocate Aurora Health, calls for dual transformation, finding new ways to be profitable while also making a bigger impact on health and helping people live well. The shift in hospital investment. With Amazon and other disruptors in the game, traditional health systems are rethinking their strategy. A 2023 survey of top U.S. hospital systems found that most are investing in virtual health, remote monitoring, and digital front doors to reimagine access. Fewer are pouring money into flashy new buildings. The trend is toward fewer physical facilities and more digital portals, less about architectural statements and more about functional, accessible care. Competing retail models, Amazon versus Apple. Amazon's model is all about quick delivery and low cost, but there's also the Apple approach, less about customer obsession, more about creating must-have innovative products. Some academic medical centers, AMCs, are betting on the Apple model, building high-tech look-at-me hospitals. But as day-to-day care becomes more commoditized, these centers may find themselves ceding routine care to disruptors like Amazon, focusing instead on high-end specialized therapies. The data dilemma. Amazon's success relies on its mastery of data and logistics. But in healthcare, data privacy is paramount. It's one thing for Amazon to recommend a book. It's another to have Alexa monitoring your health and suggesting products from Whole Foods. As we add more digital interfaces, we risk losing the personal connection that's so vital in medicine. There's a real danger that patients become data points and care becomes transactional. Google's disruption, AI and data analytics. Google is taking a different tack, leveraging its strengths in AI and data analytics. Google's Healthcare Studio gives clinicians an integrated view of patient records, while Google's Cloud Healthcare Data Engine unifies datasets for better population health insights. Google's AI has shown promise in detecting breast cancer and mammograms, sometimes outperforming radiologists. But many AI breakthroughs don't translate perfectly to real-world care. For example, an AI model for predicting hospital infections worked well in the hospital where it was trained, but not at another. Validation and context matter. Google's AI overviews, which uses generative AI to answer health questions, have also produced some bizarre and even dangerous advice, like recommending people eat rocks for minerals based on a satirical article. This highlights the risks of relying on AI without proper oversight. That satirical article was in The Onion. The Costco and Walmart experiments. Costco, in its partnership with Sesame, now offer virtual primary care visits for just $29, targeting both the uninsured and those who value instant access. Walmart, with its vast rural footprint, seems poised to revolutionize rural healthcare with in-store clinics. But in 2024, Walmart closed all 51 of its health centers and its virtual care offering, citing an unsustainable business model. The lesson? Healthcare isn't retail. Personnel costs don't scale like inventory, and you can't upsell a health screening like you can a pack of gum. Other retailers have faced similar setbacks. Walgreens scaled back its investment in VillageMD after heavy losses, and CVS has closed dozens of clinics despite being a leader in in-store health. The message is clear. Retail strategies alone aren't enough to solve healthcare's unique challenges. Nonprofit alternatives and new models. Not all new models are profit-driven. Risant Health, a nonprofit created by the Kaiser Foundation Hospitals and Longitude Health, launched by 4 nonprofit systems, are focusing on evidence-based care and operational improvements rather than maximizing profits. These mission-driven models may offer a more sustainable path forward. Rethinking primary care. The rise of retail medicine is changing what patients expect from primary care. Telehealth, direct primary care memberships, and wraparound services are becoming the norm. There's a push to train more primary care providers through condensed technology-enhanced medical school tracks. Medicare is even planning to cover a version of direct primary care. Hybrid models like Cleveland Clinic's Express Care Online blend virtual convenience with the option for in-person follow-up. But this convenience comes with risks. Fragmentation is a real concern. Patients might get care from Amazon, Costco, a mobile clinic, and their regular doctor, with no one coordinating the big picture. Older patients may stick with traditional care, while younger, tech-savvy patients embrace the new model, creating a generational divide. The future? Fewer hospitals and more home care. Looking ahead, I see a future with far fewer people in traditional hospitals. Telehealth, ambulatory centers, and home care will handle most routine needs, freeing up hospital beds for the sickest patients. Care will be more transactional, with less time for relationship building, but home care can be just as effective and sometimes better than hospital care. Retail medicine disruptors will have their biggest impact here, handling routine, non-acute care, while AMCs and hospitals focus on complex, specialized treatments. The challenge for all of us is to collaborate, standardize care, and ensure that innovation truly improves health outcomes. The takeaway is this. Healthcare is now undeniably a business, but it's a business with a mission. Retail medicine is here to stay, and it's changing everything from how care is delivered to what patients expect. The winners will be those who adapt, collaborate, and keep the focus on improving health, not just cutting costs or chasing profits. The future belongs to those who can blend the best of retail convenience with the heart of medicine. Let's make sure we're ready. Chapter 3. New Alternatives to the Pharmacy. Let's talk about the pharmacy, an institution that, like VHS tapes and phone booths, is on the verge of a major transformation. The principle guiding this chapter is clear. Medicines and treatments in the U.S. are far too expensive, and as medical discovery accelerates, this problem will only get worse. But disruptors are stepping in, offering new models that could finally break the cycle of high costs and limited access. The pharmacy at a crossroads. Think back a few decades. Independent pharmacies were everywhere. A trip to the pharmacy meant a real conversation with a knowledgeable pharmacist. Today, nearly half of those independents are gone, replaced by giants like CVS and Walgreens. But even these mega chains are now the old guard, and they're struggling. If you filled a prescription lately, you know the drill: long waits, out-of-stock meds, and little to no interaction with the pharmacist. It's a far cry from the personalized service that's still common in places like Germany, the UK, or Australia, where pharmacists are integral to primary care teams and focused on dispensing medications and offering advice, not running convenience stores. The decline in service and rise in inconvenience has created huge opportunity for disruptors. The U.S. prescription drug market is massive and growing. Per capita spending jumped from $101 in 1960 to $1,150 in 2021, and the number of prescriptions filled has soared from almost 4 billion in 2009 to 6.7 billion in 2022. But with this growth has come skyrocketing costs. Prescription drug prices in the U.S. are on average 2.5 times higher than in other developed countries. And for brand name drugs, the gap is even wider. The result, only about 55% of Americans can afford and access the prescription drugs and quality health care they need. This is not just a statistic. It's a crisis that's opened the door to new players to offer more affordable, convenient alternatives. Amazon's pharmacy play. Amazon's entry into the pharmacy world has been both strategic and disruptive. It started with the acquisition of PillPack in 2018, a company that pre-sorted medications into daily doses and delivered them to patients' homes. Amazon then launched Amazon Pharmacy in 2020, allowing customers to manage prescriptions, compare prices, and check out, all online or through the app. One standout feature is the price comparison tool, which lets customers see the cost of their medication with insurance, without insurance, and with Amazon Prime's prescription savings. This level of transparency is a sharp contrast to the opaque pricing at traditional pharmacies. In 2022, Amazon introduced RX Pass, a subscription service for Prime members. For $5 a month, you can get all your eligible generic medications filled as often as needed. While the list of covered drugs is limited, it's a novel approach that's already shaking up the market. Mark Cuban's Cost Plus Drugs. Entrepreneur Mark Cuban is taking a different approach with his Cost Plus drug company. The model is refreshingly simple. Buy drugs directly from manufacturers at a flat 15% markup, a $5 pharmacy, and $5 shipping. No middlemen, no hidden costs. The savings can be dramatic. Adenib, a leukemia drug that can cost over $2,500 a month, is just $17.10 through Cost Plus Drugs. Most of the company's offerings are generics, but the impact is real. A study found that if Medicare had bought 77 generic drugs at Cost Plus prices, it would have saved $3.6 billion in 1 year. As of early 2024, 2 million customers had switched to Cost Plus, which now offers over 2,500 drugs and is expanding into brand name medications. Cuban's company even opened a robotic plant in Dallas to produce injectable drugs that are often in short supply, aiming to respond quickly to shortages while keeping prices low. Of course, there are challenges, especially the complex relationship between drug manufacturers and pharmacy benefit managers, PBMs, who are now launching their own cost-plus networks in response to Cuban's model. But the disruption is real, and the industry is taking notice. The power and problems of PBMs. PBMs are the middlemen of the pharmacy world, and they wield enormous power. The three largest, CVS Caremark, Express Scripts, and Optum Rx, control prescriptions for over 200 million Americans and process about 80% of all U.S. prescriptions. Their stated goal is to lower costs, but investigations have shown that PBMs often do the opposite, steering patients to more expensive drugs, charging employers and Medicare multiple times the wholesale price, and collecting billions in fees from drug companies. PBMs profit most from high-cost drugs, so they pressure manufacturers to raise list prices, which in turn increases their own profits through larger rebates. Patients, meanwhile, often pay out of pocket based on the inflated list price, not the discounted one. PBMs also drive up costs for generics by steering patients to their own pharmacies and squeezing out independents. This has fueled the rise of disruptors like Amazon and Cost Plus, who offer transparent pricing and direct-to-consumer models. Large employers and health systems are taking notice. Community Health Systems, CHS, partnered with Cost Plus for its 71 hospitals, and Blue Shield of California created a hybrid model using Cost Plus, Amazon Pharmacy, and CVS Caremark for specialty drugs, projecting $500 million in annual savings. Switching PBMs can be disruptive, and the biggest PBMs are often tied to major insurers, making it hard to shop around. Patients are left navigating a confusing, opaque system, often paying more than they should. Toward transparency and competition. Some states now require drug pricing transparency, but more is needed. I believe we should do the following 4 things. Require PBMs to disclose all fees and rebates. ensure patient out-of-pocket costs are based on net prices after discounts, encourage alternative PBM models that align with patient and employer interests, and promote competition in alternative drug delivery models to reduce PBM power. The pharmaceutical sector is perhaps the most profit-driven and least patient-focused part of healthcare, but the tide is turning and greater competition, transparency, and direct-to-consumer models are gaining ground. Beyond online ordering, tech, and the future of the pharmacy. Innovation isn't just about online ordering. AI and machine learning are being used to improve medication management and prevent dangerous drug interactions. Companies like MediSafe use AI to create personalized medication reminders and track adherence, helping patients manage complex regimens. Blockchain is being explored to secure the pharmaceutical supply chain and combat counterfeit drugs. And 3D printing could one day allow for a custom-dosed, highly personalized medication. Imagine a pill printed just for you on demand. Some of these ideas are still futuristic. For example, a consulting firm once imagined a scenario where a smart toothbrush detects strep, sends a sample to a lab, and a 3D printed pill is delivered to your door within hours. Well, that's a bit too optimistic for now. It shows the direction we're heading. The changing role of the pharmacist. So what does all this mean for pharmacists? To stay relevant, they'll need to specialize, perhaps joining primary care teams, managing chronic conditions, or focusing on personalized medicine. 20 years ago, it was rare to see pharmacists rounding with doctors and nurses in hospitals. Now it's common and highly valuable. Pharmacists could also play a bigger role in addressing social determinants of health and ensuring medication compliance. Pharmacies themselves will need to evolve, offering not just prescriptions, but a full suite of health and wellness products. Think diabetes supplies, dietary products, and telehealth consultations with pharmacists. The goal is to restore that trusted one-on-one relationship, even as the business model changes. The era of the corner pharmacy is ending. The pharmacy landscape is diversifying. Mail order and online pharmacies, direct-to-consumer models, and tech-enabled services and specialized pharmacies are all part of the new ecosystem. Patients will have more options than ever, but this also means more fragmentation and new challenges for care coordination. The core mission of the pharmacy, getting patients the medications they need, remains unchanged, but who provides that access and how is evolving rapidly. The innovations we're seeing offer hope for a future where prescription drugs are more affordable and accessible. But to realize this potential, we'll need ongoing collaboration between traditional providers, new entrants, and patients themselves. In 10 to 15 years, I suspect few pharmacies will be brick and mortar. Today's pharmacists must prepare to step out from behind the counter and become essential members of the care team, delivering not just prescriptions, but truly personalized healthcare. Chapter 4. The Expanding Scope of Obesity Drugs. Let's have an honest conversation about obesity, arguably the greatest epidemic of our time, and one that's only getting worse. The numbers are staggering. By 2030, nearly half of U.S. adults are expected to be obese, and by 2050, that figure could climb to 2 out of every 3. Obesity isn't just a cosmetic issue, it's a root cause of countless chronic diseases, from diabetes and heart disease to sleep apnea and joint pain. The burden on our healthcare system is immense, and our current approaches simply aren't working. A new hope: breakthrough medications. Enter a new class of obesity drugs, GLP-1 receptor agonists like semaglutide, Wegovy, and tirzepatide, Zepbound. These medications are nothing short of revolutionary. They work by enhancing insulin secretion, slowing gastric emptying, and promoting satiety, but their impact goes far beyond weight loss. They're showing promise in reducing addictive behaviors thanks to their effect on dopamine pathways in the brain. Early studies suggest benefits for alcohol use disorder, smoking cessation, and even opioid addiction. Imagine a single medication that not only helps you lose weight, but also lowers your risk of heart attack, stroke, and cardiovascular death by up to 20%, improves blood sugar, reduces inflammation, and may even slow the progression of diseases like Parkinson's and Alzheimer's. The complexity of obesity. Obesity is a disease, but its causes are complex. Lifestyle and environmental changes, think calorie-dense, ultra-processed foods and sedentary living, are major drivers. Socioeconomic factors play a role too, as Underserved communities often lack access to healthy food and safe places to exercise. Psychological and biological factors, including chronic stress, mental health issues, sleep deprivation, and genetics, further complicate the picture. Food science has engineered products that hit the bliss point of sugar, salt, and fat, making them irresistible and addictive. The result, an environment where making healthy choices is incredibly difficult. The promise and the challenge. I've seen plenty of miracle cures come and go, so I approach new treatments with healthy skepticism. But these new drugs are different. For the first time, we have medications that can produce sustained weight loss of 15 to 20% or more, far beyond what most people can achieve with diet and exercise alone. This level of weight loss leads to dramatic improvements in obesity-related conditions and may even reduce the stigma around obesity by highlighting its biological underpinnings. But there's a catch. These drugs are expensive, often costing hundreds of dollars a month. While prices are coming down, they remain out of reach for many, and insurance coverage is spotty at best. Federal government and insurers are balking at the idea of covering these drugs for everyone who needs them, citing the enormous potential costs. For context, if half of Americans with obesity took these drugs, it would cost $411 billion annually. Even Medicare and Medicaid could see these costs soar by $166 billion a year. Novo Nordisk's CEO, Lars Fruergaard-Jørgensen, argues that the upfront cost of these drugs could be offset by the savings in other areas: reduced disability payments, fewer hospitalizations, and lower absenteeism. Some physicians advocate for an obesity-first approach, treating obesity aggressive to prevent or reverse other chronic diseases. But we don't know yet if the long-term savings will materialize, and the debate over who should pay and who should benefit will only intensify as more breakthrough treatments emerge. Who should get these drugs? With 70% of American adults overweight or obese, the potential market for these drugs is massive. Should we treat obesity as a chronic condition, like hypertension or diabetes, and offer these medications to everyone who qualifies? Or should we reserve them for those at highest risk? There's also the question of prevention. Should we use these drugs in people who are just overweight, or even in children and adolescents at high risk? The ethical and practical implications are enormous, especially since these medications may require lifelong use to maintain their benefits. The role of precision medicine. As with statins for cholesterol, I expect we'll see a move toward more targeted use of obesity drugs, identifying those most likely to benefit based on genetic markers, body composition, or other factors. This precision medicine approach will help maximize benefits while controlling costs, but it will require changes in how we conduct clinical trials and approve new drugs. What's the federal government's role? Making these drugs widely accessible will require bold action. Federal government could purchase large quantities and distribute them at low or no cost, especially as they become available in pill form. This would not only help combat the obesity epidemic, but also set a precedent for addressing other public health crises. Influential voices like Elon Musk have called for making GLP-1 drugs super low cost to the public, arguing that nothing else would do more to improve Americans' health and quality of life. Rethinking chronic disease management. These new medications force us to rethink our entire approach to chronic disease. Instead of waiting for conditions to develop, we now have tools to intervene early and reduce lifetime risks. But this shift raises new questions. Should we use these new drugs preventatively? How do we balance personal responsibility with medical intervention? And how do we ensure equitable access without bankrupting the healthcare system? The bigger picture. Obesity's rise is a symptom of broader societal changes: food science, sedentary lifestyles, and environmental factors. While policy interventions like taxing unhealthy foods or designing walkable communities are appealing, there are no quick fixes. The rise of effective obesity drugs should be met with cautious optimism, leveraging these tools wisely and sustainably to make a lasting impact on public health. We've entered an era of true wonder drugs, and obesity medications are at the forefront. If we get this right, we could dramatically improve health outcomes and reduce healthcare costs. If we get it wrong, we risk deepening disparities or creating new problems. The next few years will be critical as we navigate these challenges, balancing scientific potential with practical realities. The story of obesity drugs is a test case for how we'll handle future breakthroughs, one that will shape the future of medicine for decades to come. Chapter 5, The Virtual Overhaul of Behavioral Health. Let's talk about a crisis that's been quietly growing for decades, the epidemic of behavioral and mental health disorders in the U.S. The need for care is overwhelming our system, leaving millions without essential support. But there's hope. Disruptors are stepping in, offering new ways to expand both primary care and self-care. And these innovations could be the key to finally making a dent in this crisis. Destigmatization and overlapping realities of mental and behavioral health. One of the most profound changes I've witnessed in my career is the growing understanding and destigmatization of mental and behavioral health. The American Medical Association defines behavioral health as encompassing mental health, substance use disorders, life stressors, and stress-related physical symptoms. These issues are deeply intertwined. Mental health problems can drive unhealthy behaviors, and unhealthy behaviors can worsen mental health. Yet, despite increased awareness and public health campaigns, we haven't seen a corresponding improvement in access to care. A system under strain. The U.S. system is woefully unprepared for the current demand. Starting in the 80s, reimbursement for inpatient mental health care plummeted, leading to a halt in building new facilities just as the need for care began to surge. Outpatient and home-based care have helped many, but for those in acute crisis, the system is failing. Patients can wait days in ERs for a bed. The infrastructure simply isn't there. The numbers are sobering. About 1 in 5 U.S. adults lives with a mental illness. And the rate is even higher among young adults. 1 in 6 Americans aged 12 or older struggles with a substance use disorder. While some of this rise reflects greater willingness to seek help, it also points to the growing stresses of modern life. The challenge of building capacity. Behavioral health programs are largely state-based with little federal involvement. Reimbursement is low, making it hard for providers to break even, and many hospitals have actually reduced their behavioral health services. Even when there's state support, as in Michigan, building new facilities can be stymied by local opposition and financial hurdles. For example, when we tried to convert a dilapidated high school in Lansing into a psychiatric hospital, we faced pushback from groups wanting to preserve the building as historic. This is a microcosm of the challenges faced nationwide. Disruptors to the rescue, virtual and digital care. Given these barriers, it's no surprise that disruptors are flooding into the mental health space. Mobile apps and online portals are making it easier for people to access care, especially in rural or underserved areas. Teletherapy offers flexibility, privacy, and continuity. Patients can keep seeing their provider even if they move. Studies show that teletherapy is as effective as in-person care for many conditions and sometimes even preferred by clients. AI and big data are poised to revolutionize behavioral health. Predictive analytics can identify people at risk for mental health issues or substance use disorders, allowing for early intervention. AI can optimize treatment plans, analyze speech and behavior for diagnostic clues, and even predict relapses. But we must be cautious. Data privacy, algorithmic bias, and the risk of over-reliance on technology are real concerns. The rise of AI-powered mental health apps. Apps like Headspace have brought evidence-based meditation, mindfulness, and therapy to millions, over 70 million downloads, in fact. Headspace Health has acquired AI-driven companies to create a more integrated experience, using AI to recommend content and foster healthy habits. Other apps like Nomi and Kindroid offer AI-powered companions that provide advice and support. A Stanford study found that students using these AI social agents reported increased feelings of support and decreased anxiety. But let's be clear, AI bots are not a replacement for real human relationships or professional care. They can be helpful, but they can't truly empathize or provide in-depth support that trained counselors offer. There have even been tragic cases where reliance on AI advice has led to harm. These tools are best seen as complements to, not substitutes for, professional care. Evidence for digital interventions. Dr. Srijan Sen at University of Michigan has shown that evidence-based apps and wearables can reduce depression, anxiety, and suicide in patients waiting for traditional care. In a study of 2,000 patients, those using mindfulness, cognitive behavioral therapy, or mood tracking apps saw measurable improvements in just 6 weeks. Wearables are also being used to track depression triggers and responses, offering new insights for both patients and providers. The incentive puzzle. Changing behavior is hard, and most incentives, like free gym memberships, don't work. The only consistently effective incentives are direct financial rewards, such as lower insurance premiums or cash for meeting health goals. But insurers are reluctant to offer these since the financial benefits often accrue years later after patients have switched plans. This is a challenge not just in behavioral health, but also with new medications like GLP-1 anti-obesity drugs. Novel treatments for depression. New therapies are emerging for treatment-resistant depression, including deep brain stimulation, non-invasive nerve stimulation, psychedelics, and especially repetitive transcranial magnetic stimulation, which is non-invasive, effective even in tough cases, and can be delivered on an outpatient basis. It's a game changer for many patients. Empowering providers and rethinking payment. We need to empower primary care providers to take a more active role in promoting healthy behaviors with specific plans for diet, exercise, sleep, and stress reduction. This could include integrating nutritionists and health coaches into care teams, but our current reimbursement system doesn't support this. RVUs, relative value units, reward procedures, not prevention or counseling. We need to assign higher value to comprehensive health planning, tie reimbursements to outcomes, and pay for virtual check-ins and patient-reported data. The transition to outcomes-based payment is coming, but it's complicated. Some countries like Germany and the UK have incorporated quality and outcomes into their systems, but the US is still figuring out how to make this work. Beyond the usual suspects, systemic solutions. We can't meet the demand for behavioral health without making tough choices. Expanding care will cost money, and insurers are skeptical that prevention will save enough to offset these costs. The U.S. is already spending over 17% of GDP on health care. We may need to consider models like Denmark's, where primary care acts as a gatekeeper, or a two-tiered system with a basic safety net and optional higher-level care for those who can afford it. States like California are experimenting with integrating health and social services, while cities like Philadelphia are trying new approaches to substance abuse, sometimes shifting from harm reduction to more coercive models. None of these solutions are perfect, but bold experiments are needed. For too long, we've treated physical and mental health as separate. It's time to break down those silos and create collaborative care models with mental health professionals working alongside primary care providers and digital disruptors. Shared electronic health records, embedded behavioral health professionals, and stepped care approaches that match patients to the right level of care are all part of the solution. We must remain vigilant about privacy, equity, and the importance of the human connection. The future of behavioral health is bright if we harness disruptive innovations thoughtfully and responsibly. By doing so, we can dramatically improve outcomes and well-being for millions of Americans. So that's where we'll leave it for this week. This has been part 1 of The Great Healthcare Disruption by Marshall Runge, MD. We'll pick up with Chapter 6 next week. And know that I have many resources for innovators, people building products, and learning AI on my website, InnoGuide.net. I want to thank Steve McIntyre for producing this, and I want to thank you for joining. That's a wrap. We'll see you next time.